So similar to the neurocognitive deficits that Dr. George really was talking to me about many, many years ago, he'd also been talking for many years about issues with mood disorder and depression. And certainly if you talk to our cohort of patients in the clinic when you see them, just the awareness of these issues lets you ask the correct questions. And there's no question we see a large number of patients with depression, mood disorders, anger management, impulse type behaviors, but it's been difficult to sort of absolutely and objectively measure this. But this is exactly what Dr. George and his group did. And these, again, were data presented at ASH this past year. They used the Beck Depression Inventory 2 from patients from 2004 to 2011. It's the 21-question screening measure for depression within the previous 2 weeks. Patients after this who were identified with this screen were then underwent structured psychiatric interview to really definitively diagnose if major depression is there to allow intervention if needed. So 47 patients over this 7-year time period were screened with this inventory. 15% of patients were found to have severe depression by this measure, subjective measure, at least once, with 15% excuse me, documented to have moderate depression at least one time when they were tested. Again, patients were tested 1 to 5 times during this study period. If you look at the patients who then underwent these psychiatric interviews, the formal interviews, in the 15 patients with judged to have severe depression by this index, 12 patients survived and 10 of them underwent psychiatric interviews, with 90% of them, or 9 of the 10, being diagnosed with a major depression. Of the 1 patients judged to have moderate depression, 7 survived, 4 of the 7 underwent the psychiatric interview, and 1 of these patients was found to have a major depression. So it's certainly starting to validate what was seen clinically, what patients were telling us at patient support groups and in the clinic. They also used another depression measure. The Oklahoma group did the Patient Healthcare Questionnaire 8. These were an 8-question questionnaire used as a screening measure for depression within, again, the previous 2 weeks. It's also important to note that patients were screened at about 6.3 years from their initial episode of TTP, with a range of 1.79 to 16.1 years from their initial episode of TTP. So this isn't just happening right at the time of the diagnosis. This is happening during long-term follow-up. These issues seem to be developing. It's important, though, to compare the development of depression by this index to other standards to know if there really is an increase, and certainly that appears to be the case when compared to the percentage of patients with this index that will be diagnosed with a major depression. Looking at U.S. norms at 3.4%, but also Oklahoma norms, again standardized for age and sex, certainly a significant higher rates of severe depression in these cohorts of patients. So I think this really sort of puts us in objective terms and tells us that the prevalence of major depression is significantly higher in patients during long-term follow-up from recovery of a previous diagnosis of TTP. And again, it comes down to sort of understanding this, the awareness of this, allowing you to ask the right questions. Without asking patients the right questions in that outpatient clinic, these are likely to go missed, as patients may not bring this up thinking it's not related to the TTP, think it's not a problem, or just really not aware that this is a potential complication. So again, going back to the awareness is the main thing for physicians to sort of convey these issues to patients, to sort of intervene early whenever possible. So switching a little bit from long-term complications, we're concluding with a common issue in patients with a previous diagnosis of TTP. And certainly pregnancy is a common feature when patients can present with a diagnosis of TTP, but especially also atypical HUS. The question is always, what is the risk of a future pregnancy, and can patients get pregnant in the future? This causes significant stress, obviously, with this disorder, as the majority of them are females, and young females typically, who want to get pregnant in the future. So the Oklahoma group looked at their own registry and looked at 20 women with 35 subsequent pregnancies, but also did a systematic review of all published case reports of patients with a diagnosis of TTP who subsequently got pregnant. Now, this was published initially in 2004. But what's interesting, if you look at the Oklahoma group and their patients that they categorized clinically as idiopathic or acquired TTP, recurrent TTP with a subsequent pregnancy occurred 27% of the time. Certainly much higher than lower than what's published in the literature. If you look at it in the published literature from patients with subsequent pregnancies, you see 61% of patients develop recurrent TTP. So what are the reasons for this discrepancy? Are the patients that different? Probably not. This probably represents a reporting bias, as when you have a patient with a history of TTP who develops TTP with a subsequent pregnancy, you're more likely to report this, whereas the patient with a previous history of TTP who does well during their pregnancy is less likely to be reported in the medical literature. They also looked at pregnancy-associated TTP, and if you look at the Oklahoma cohort, there was a 9% rate of recurrence in patients with a previous history of pregnancy-associated TTP. And again, looking at the literature, 46% of patients with a previous history of pregnancy-associated TTP suffer a recurrence. So it really doesn't seem that clinically, the clinical categorization of having TTP with a previous pregnancy is absolutely predictive of who is going to relapse in the future. So obviously this is certainly a significant issue, and one that Marie Scully and our group have looked at. They did a very interesting study now more than 5 to 6 years ago, looking at 5 patients with a previous history of TTP. So 5 cases here. 3 of the 5 had pregnancy-related cases, and this is cases 1, 2, and 4 that you see in this table below. 1 of the 5 patients had multiple episodes, and that would be case number 3. The first 4 patients required plasma exchange therapy based upon pre-treatment ADAMTS13 activity. So the patients who had severely deficient ADAMTS13 activity were not followed, were preemptively treated with plasma-based therapy. In the case of patient number 4, she received rituximab therapy as well based upon the concern. Patient case number 5 had measurable, we say, ADAMTS13 activity pre-pregnancy and maintained this throughout, never getting into trouble. So certainly raising the question, is it the ADAMTS13 activity that can predict the risk of developing TTP in a subsequent pregnancy? The first 4 cases obviously were treated with improvement in the ADAMTS13 activity, but it doesn't really accurately answer the question, what happens with an untreated severe deficiency of ADAMTS13 going into pregnancy? So we published now just a couple of years ago some work looking at 5 pregnancies from a total of 3 patients. 1 of the patients did have a history of pregnancy-related TTP at 22 weeks gestation. The other 2 patients had idiopathic TTP, not thought to be related to pregnancy. All 3 had severely deficient ADAMTS13 activity. And I think what you saw was quite striking. In the first patient, what you see shown here is the first 3 episodes from this first patient. She initially presented with no known history of TTP, but was diagnosed during her pregnancy. She chose to get pregnant again, was severely deficient in the ADAMTS13 activity pre-pregnancy, and was so during the early parts of her first and second trimester. But unfortunately, as you can see, similar to her first pregnancy, her first presentation, she developed TTP at approximately the same time of gestation, 21 to 22 weeks. Interesting, in her case, she chose not to get pregnant again, or so she told me, but called me about a year later, and as you can see, the 3rd pregnancy is listed there. She obviously had something to tell me. What she told me is that she was now pregnant again. She was treated before with cyclosporin due to the refractory nature of her previous TTP episodes, but chose to stay on the cyclosporin. So when she got pregnant now and called me at about 15 weeks gestation, she was already on cyclosporin at the same dose. So after some long discussions about the risks and benefits, she decided to continue therapy, which is really her intent from the very beginning. And as you can see, she maintained measurable or above 10% ADAMTS13 activity throughout her pregnancy. She did not develop TTP, delivered a child at roughly 25, 26 weeks of gestation, complicated by preeclampsia, but again, no evidence of the thrombotic microangiopathy. Her daughter's doing quite well today. What's also just as striking is patient number 2, again with a previous history of TTP, did fine through most of her pregnancy with severely deficient ADAMTS13 activity, and we thought maybe she was going to make it, but unfortunately developed TTP at 37 weeks of gestation. It's also important to notice the 2 patients circled in yellow. So 3rd episode of patient number 1 and our patient number 3. So in recovery, she had normal ADAMTS13 activity, independent of any therapy, plasma, rituximab, cyclosporin, and maintained a normal ADAM-TS13 activity throughout her pregnancy, never getting into trouble, certainly is suggesting to us that it's not necessarily a history of pregnancy-related TTP, but it may be actually the ADAM-TS13 activity. And when it's severely deficient, there is a significant increased risk of developing a TTP, raising the question of should we be doing prophylactic therapy with either cyclosporin, plasma-based therapies, or even rituximab, as you saw in the previous report from Dr. Scully. This actually database is now expanding as there's now 7 pregnancies from 4 patients with these same data holding up. And actually our first patient is now on her 4th pregnancy, but doing well with measurable ADAM-TS13 activity, now at 25 weeks gestation on prophylactic cyclosporin. So I think these data give some hope to the future in helping address this question with patients, knowing that we have ways to potentially predict the risk of developing TTP in subsequent pregnancies, but also something we can do to intervene to prevent this, I think. So I think in summary, I think really the last several years we've seen a significant increase in our knowledge of the long-term complications from a previous diagnosis of TTP, and also the significance of them in terms of decreased survival. There are more patients surviving, and these are going to be more important issues going forward, more and more. Neurocognitive, vascular, and psychiatric complications are certainly more common than we recognized previously. This has always been the case, but again, I think without the idea to be looking for them and asking the right questions, these issues were passed on and attributed to something else is thought to be not related to their TTP. But I think the most important thing is point 3, this increased awareness should lead to efforts to identify these in patients and prevent, I believe, some of the morbidity and mortality that can be seen related to these chronic complications.